once flipper is out, it is checked twice.
So this is the real life implantation. I have made a scleral tunnel and I am just pushing the IOL through the main port. It was a traumatic case, and here, as we can see, I am just pulling the flipper out from one scleral port, and the flipper is totally out here, as we can see. And the same thing I'm doing on other side. Once it's done from other side, and we just have to pull it out. Once it's totally out, we just have to see like that. If the whole flipper is out and we can see the whole neck part, then there's no issue. It can't go back inside. It's simple technique like what is there in price tag labels. So it's very simple technique. It hardly takes 10 to 15 minutes, nothing more. And it's like the amount of armamentarium of what we need, like different kind of glues we need or different kind of sutures and all, it's not at all needed here. I'll just share one more video of my good friend, Dr. Rohit. Is it visible now?
Yes.
So these are the basic steps. So here the scleral pockets are made like this. He's doing just flensectomy. I'll just go to the main parts. So this IOL is of size of 14 millimeter and it can stretch up. So even in smaller or larger eyes, it can be fixated. And here it has been injected with the injector. And simply the leading haptic, the flipper is pulled out. The flipper is pulled out like this. Once the whole flipper is out, one side of surgery is over, and on the other side, it's a similar thing. The flipper is held with mesh grip forceps or ILM forceps, and it can be just pulled out, and its surgery is totally over. And if you want to suture it, it's your wish. If you don't suture it also, it stays at its place. So it's a very simple surgery and it's a very simple technique. It's not some rocket science, but what day to day what we use it, I have incorporated it in this IOL. So thank you.
Is it a hydrophobic material or hydrophilic material? The lens.
Sir, lens is hydrophilic.
Okay.
And what is the A constant of the lens? I mean,
it's a 117.8, I think. Exactly, I have to check.
so how many
So I hope I have changed your perspective of IOL.
No, only thing is that we'll have to see how much refractive surprises you are getting and how many lenses have been used so far, so that we can really find out what will be the right A constant for that. So so far, I mean, you need to have a little more people using it. How many lenses have been used so far?
So more than 1,500 lenses have been used.
Okay, that's great. That's
so it's freely available in India right now. It's marketed by Omni, and it's freely available, and so many of the doctors are using it in day-to-day practice. And mainly one thing over scleral fixated lens or other lenses, like it is 4-point fixated, so haptics becomes V-shaped. Like as you have seen here in C shape, it is stretchable. So when we pull it out from there, so it becomes V shape, and the stability, the pseudo-phacodonosis is very minimal in this. And the optic is very large. So in case
No,
of
I'm
like
convinced that the lens is good and fixation is excellent. I got no doubts about that. So only thing I'm worried because nowadays we definitely look into the final outcome, and we need to have a really good A constant to know that what exact power. I mean, now not only we are looking at just putting an IOL over there, we're looking at a spectral freedom also, and of course the type of design you have. Maybe you can have a customized toric IOL as well, which can be
it's
given at
possible.
any particular axis, because you know that the lens is going to be fixed at 9 and 12, and you can, if not develop, you can develop the toric IOL for the same, which can be customized in order. But only thing is I'm just concerned about the A constant, how much dot on a spot on you are. And if not already done this study, then I'll request you to please ask your users to send their data, what happened post-op, what was the post-op reflection, so that you can refine the A constant. Just a suggestion. Otherwise,
Yes,
excellent,
definitely, sir,
excellent
will do that.
innovation, excellent innovation.
How
Thank
big
you.
is
Thank you so much.
how big?
Dr. Saurabh, Dr. Kiranjit, sir.
Yeah. So I think the Carlywell IOL was in Europe since long time, and it's a very established IOL. And we are looking for similar IOLs in India. I think thanks to Dr. Rana, that this kind of design is available. I'll use similar IOLs. One of the key things is while you pull out the T junction or the flipper, you have to be careful not to break it, because that may be an issue which may be less with Dr. Rana's IOL, because I think he uses a bigger shoulder or bigger neck there, which goes through 20 gauge, while the other IOL CMT Flex has a smaller size neck, which goes through 23 gauge, but it may be little fragile, because I usually use the same IOL for training my fellows, because I feel this is the easiest technique to do for particularly in beginners' hands as compared to the Agarwal's technique or even the Yamane technique. I think this is more forgiving. Even if you get breakage of the haptic, you can just remove that IOL and put another IOL. So very good IOL design, very stable. I haven't faced many issues. One of the issues may be that Carlywell IOL has a kind of a shoulder to make it more stable, more parallel once it goes into the eye. Some of these IOLs, they do not have the same design, so there might be an issue of tilt later on, which you have to watch out for. So before you put a glue, just the flipper should be exactly, parallel when you glue it. If it is little tilted, you may have little tilt post-operatively. That is something we have to be little careful about. Otherwise, the easiest technique which I have so far done for a scleral fixated eye.
Thank you, sir.
Thank you,
Kiranjit,
sir. Thank you,
Uh,
sir.
you see,
Just one correction, sir. This IOL was actually patented in 2017. It was marketed in 2020, but it was patented in 2017. So before all this IOLs, it was first patented. I designed it during my fellowship period in 2016. So in 2017, I had the patented ready that time, and then we started doing research and we modified a little bit, and then finally we marketed in 2020. But thank you so much, sir, for this encouragement, sir. Thank you, sir.
So my question is, or my amazement is, the lens is very good. It is very nice fixation, but my concern is a simple case of subluxation. We can easily deal through an interior approach, and we are simply converting a simple case into a VR case. And as far as I have seen the videos of Dr. Jan Wurst, vitreous is not just jelly. It has been shown by Dr. Jan Wurst. It has cisterns. It has so many channels inside it. So we should try to preserve the vitreous as much as possible. It is not a vestigial organ. It should be preserved. It should be respected. So as little vitrectomy we should be done. And if the things can be controlled through an interior approach, it should be done to avoid a VR surgery, which is very
Very,
invasive.
very
Okay.
true, sir. So basically, I'm not a cataract surgeon. And whenever I get the case, when cataract surgeon is not ready to do the case, then only we touch the case in cases of subluxation or phacodonosis. Otherwise, usually we don't touch the case until unless a anterior segment surgeon is sending me a case that you do the case, I won't be able to do it. Then only we touch it. Otherwise, even my preference is the same. Like you try to do it once. If it's not possible for you, I'll definitely take over the case. So I agree with you, sir, on this.
Any last comments from Guru Prasad, sir?
So I have two concerns. One is about placing the IOL over the iris in the beginning. And if the pupil is widely dilated, there's a small chance of a dislocation of the IOL itself before we do any further manipulations. I think that we need to have a mid-dilated pupil rather than a fully dilated pupil, like I prefer for iris claw lenses also. Number one. Number two is a question to Dr. Partha is that whether the effective lens position will depend on the corneal diameter, because the lens diameter is fixed. The overall length of the IOL is 14 millimeters or something that's what you said. But when we actually place it, does it not vary? The effective lens position will it not vary depending on the corneal diameter or the white to white diameter? This is what I want to know.
So that's what I explained first. This haptics of this lens, it's of V shape. So it is stretchable thing actually. The neck is also stretchable and the haptics are also stretchable. So depending on white to white, even like so many of the trauma cases when I do it, when trauma is there on one place and I am not able to fixate it at 3 and 9 exact, then even I try to fixate it on the cross positions. Even sometimes these cross positions are also not exactly at 180 degrees, even though the the optic size is of 6 millimeter. So it usually covers the pupil. So there's no issue in white to white diameter or even changing the angle of the lens. Usually it covers, the optic covers the lens. This lens is actually of huge size. When you inject it in the anterior chamber, you will feel it. Like you might have seen in this Dr. Rohit's case also. When it is injected in the anterior chamber, it is of huge size. So usually pupil is covered, either it's at 180 degree or not, or white to white, whatever it is. Even it's bigger size also, bigger size of white to white also, it can be covered.
Thank you, Dr.
One last point. Because of the need to do anterior vitrectomy in most of these patients, I think there will be little hypotony, and the use of an infusion either in the pars plana or an AC maintainer at the limbus, I think, is mandatory. Otherwise, the eye will be hypotonous throughout the surgery, and the lens is likely to dislocate without the support of the vitreous gel. The vitreous gel is far behind, and there is a vitrectomized anterior vitreous cavity, where the lens is likely to dislocate because of lack of support. I would like Partha to tell about
lens won't dislocate without support of vitreous. But yes, one issue is there in hypertonous cases, because we have made a very small entry and we are trying to pull out a bigger flipper through that. So when we are trying to pull it out, the eyeball's shape is kind of totally it deranges. So that's why we need a formed eyeball in this. So either we can use anterior chamber maintainer, or either we can use visco also. If we can fill the eye with visco also in this kind of cases. I have tried all the techniques and it works. But yeah, if hypotonous eye is there, and if you want to pull it out, there are chances of bleeding from ciliary body or some other issues can happen. So it is, I think it's same for all the scleral fixated iols.
Thank you. Thank you, Dr. Path. That was a wonderful presentation. Thank you, Dr. Nagesh. One quick question before Vaibhav pulls up his presentation. Why do we have that hole? Do we use it for bringing it out? Because in one of the video, I saw that it was not the hole which was used to bring it out. It was actually using the other part of that, the silicon material or the hydrophilic material. So why do we have that hole, Path?
Multiple uses of that is there. One, if you want to suture it. Second one, if you want to pull it out with ILM forceps. And third one, when we are making it for toric lenses. So in toric lenses, for marking it up on up and down on right and left side. So for all the usage, we have kept one hole there.
Okay. Thank you. Thank you very much. Thank you, Parth. Thank you, Dr. Nagesh. Now we'll move on to the next presentation is by none other than the iris claw lenses. Dr. Vaibhav Sethi, a very well-known surgeon from Delhi. So he'll be telling us about the iris claw. And after that, since Dr. Savio is an emergency duty, so I request him to go ahead before Dr. Ashraya. Small change. Over to Dr. Vaibhav Sethi from Arunodaya District Eye Hospital, Haryana.
Thank you very much. And I hope you can hear me. And
Yeah.
to
Yes.
start by saying that I think Iris Claw is a very popular choice even among the panel. We can see from the president to other senior surgeons, they all prefer to use Iris Claw. The main reason is it's easy to do and less is more, as you've learned during the session. So the lesser time you take in the eye, the better are the outcomes, the lesser the CMEs, the lesser the complications. So Iris Claw IOL to the rescue. So the first yeah. So the first scenario is a dislocated IOL. So I'll just be taking you through my approach. So you do create a sclerotomies. You make the most important part is to handle the vitreous before you put in an IOL. So as Dr. Kiranji was telling us very clearly, you have to do minimal manipulations in the eye, especially with the IOL, because in this case, there's a dislocated IOL. You must make sure you've done a thorough anterior vitrectomy. You've cleared the vitreous in this case because there's an IOL dislocated in the vitreous cavity. So you need to take it out. So you do your past plan approach and clear out the vitreous all around the IOL. If required, do a PVD as well. Once you're sure about it, you pull it up with the help of any forceps or active suction with the help of a cutter itself. And the other steps are I've already pre-made a scleral corneal tunnel. So the best approach is to create a scleral corneal tunnel which minimizes the astigmatism as well. You enter the tunnel or you pre-open it before you pick up the IOL as well to make it even more easier. You grasp and explant the IOL. So these are just certain other steps before we go in for the iris flow approach. But these are important steps. The reason being that a lot of manipulation in the scleral fixated lenses also happens in the mid-vitreous cavity, which we are not thinking about. And vitreous is a jelly, the fibers are attached to the periphery. So it's very, very important. If we do so much manipulation, you can land up in trouble if you've not checked the periphery after these procedures. So, it's very, very important to examine the retina, the periphery, 360-degree before and after you place in the lens, if you can do it before. So very important, check the patency of the haptic clips. Sometimes it might be fused, you might be surprised. It's a biconvex lens, so you won't have any problem in that. You insert it gently. The diameter is 5.5 optic with an 8 millimeter overall diameter. You rotate it 180-degree apart. I've already made the posterior limbal 180-degree stab incisions. You hold it with the help of your with any instrument which is comfortable, and there are also special designed iris claw manipulators. You can use a Sinski in the other hand. You can even place the instrument beforehand. And the most important thing is you tilt up the lens so that you see the mound of the iris, and then you press over it while you felt the clip and you see the mound and you see the enclavation. And then only you can also slightly tug on it to make sure your enclavation is perfect. So before you leave it, you can slightly manipulate the lens to see whether it's properly centered and aligned. Doing a PI is also very, very important in such cases because it prevents a pupillary block. And the important thing is you can place pilocarpine before or afterwards. The second scenario is this patient, post-trauma aphakia. There's a bad scleral tear superiorly. So here you can see the posterior limbal stab incisions 180-degree apart are very important because they prevent any corneal distortion while you're doing enclavation. So you can see the enclavation very well. Here I've created a clear corneal incision because the scleral tear was there superiorly. I didn't want to disturb it. Again, the same approach. Check the patency of the clips on both the sides. Make sure you're there. So the ease of putting it through the thing here, you can see the pupil is not constricting fully because it's a post-trauma case, but you can still place an iris claw comfortably once you do a measure. So here I've placed in the enclavation, I placed in the hydro cannula beforehand. So you hold it and you press on it, and there you can see the enclavation and you can see the dimple on the iris, which confirms that now it's in position. Very important to place the visco before you go for the other side enclavation, because there will be visco egress and there will be shallowing of the AC. So to prevent any endothelial cell loss, very important to see. I'm pulling on the iris IOL to make sure that I'm able to confirm. So you can also tap on it slightly and you basically place it back in position so it's behind the iris tissue. Now you can gently hydrate your tunnel, go in for a visco wash and clear off the minimal hyphema or something is there in the anterior chamber. It's a very stable lens. And more importantly, there have been studies that have been done, long-term studies, which have shown over the period of 103 eyes over 2 years period and even more. And this is one of the main studies by Choi and colleagues, which have shown that it's a very safe and effective surgery with refractive errors. You can get your targeted refractive outcome as well. Endothelial count loss is also not too much as comparable to stealth-fixated lenses, and IOP modulation also there. So easier learning curve, good results if done properly. Good vitrectomy is a must. This is very, very important. Check the periphery because self-fixation, you're going in the ciliary sulcus zone. Little bit manipulation, you can cause a dialysis, you can cause a tear there, which you're not noticing. And it's comparable to others. So this is a disclaimer here is any procedure that is not done properly, whether it is iris claw or self-fixation, can land you in trouble. Thank you very much.
Thank you, Dr. Vaibhav, and thank you for using this disclaimer. Is because the IOL Jawans is basically motivated from the Jawan movie, and that's why we have kept that as the IOL Jawans. So over to Dr. Kiranjit sir and Mohanta sir. Kiranjit sir, I know you have been doing the 4-point enclavation technique.
Yeah.
Now what he showed is the 2-point enclavation technique. So first I want to know what's the difference between the two. And in the first point, I saw Vaibhav using the dialer. So sometimes if we use the sharp instrument, it might cause a hole. So second time I saw him using the blunt instrument. So I just want your thoughts on this iris enclavation, sir.
As far as I'm concerned, I'm using a 26 gauge needle. I'm not using the tip of the needle, but the shaft of the needle to push the iris behind into the claw. So it will not cause any hole in the iris. And I have a question for Dr. Sethi. If he gets a microcornea with some kind of dislocation and he has to do some pars plana vitrectomy, lensectomy, and now he is there for iris claw retrofixation, and the cornea is small, overall the size of the eye is small. So what is going to be his plan of action?
So that's a tricky question.
The question is, if the eye is small, it is not possible to implant a iris claw with dimensions of 4.5 millimeter into 8.5 millimeters. So my advice is you should have smaller versions of iris claw available in your armamentarium, because you may get small eyes. So you can always tell that company who makes the lenses for you to make smaller lenses for you. And yeah, that is the point I want to stress upon. And what was
Kiranjit said, my point here was you do 4-point enclavation technique.
Yeah.
How is it? So how reproducible is it for that other surgeons can do it? I have seen it works very well in your hands, but how easy is it to do for others? Is there a learning curve for that 4-point fixation of that?
There has to be a learning curve in every new thing, but if one human being can do it, the other can also do it.
Now, what difference do you see between the 2-point and the 4-point enclavation?
There is no pseudoficodonesis with the 4-point fixation, and so many things, other things I am able to correct. So I am able to pull the iris and that helps in treating the borderline glaucoma also. At 4 points, the pupilloplasty happens by chance. So the pupilloplasty happens by chance, and phakia, of course, it is corrected. So at the very same time, I'm able to do so many things with a single thing. So that is the advantage of 4-claw fixation.
Mohanta sir, your views, and then we'll go to Savio.
Your views in about what? Iris claw?
Yes, sir.
It's a beautiful technique, particularly for surgeons who are, who don't have, who are not comfortable with pars plana approach. It's a beautiful technique for most of the surgeons. And I think Dr. Parth's IOL is very interesting. We should, I don't know, is there any comparative study between iris claw lens and that kind of lens? I don't know. but it looks very interesting. Maybe we don't, we can, if iris is not touched, then less iris pigmentation, less chance of pigmentary glaucoma in future. It could be a better option if we have that kind of lens.
Okay. Thank you, sir. Thank you very much. Good Prasad, sir. Quick comment is some patients, I think when one of your fellows have done that study, that the patients complain of shaky vision in these iris claw lenses. So how far is it true? Because I keep telling it in many of the conferences, but many of the iris claw lovers never agree with that.
Actually, if you see on the slit lamp in a vitrectomized eye, which Dr. Vaibhav Sethi showed, in a vitrectomized eye where he has removed the IOL by removing all the adhesions and almost a subtotal vitrectomy that is done, in that there is definite chance of the iris claw being so tremulous, or pseudophacodynogenesis is so severe that I'm sure what the patient is talking about, that is shaky vision that is experiencing, is true. So you have to believe him. So I have a lot of patients. That is why I have stopped doing iris claw lenses in vitrectomized eyes. In non-vitrectomized eyes, we are only limited anti-vitrectomies done. I do it, but definitely not in dislocated IOLs, where we have to do a complete vitrectomy.
Okay, I think in the cases where there is tremulousness of iris is more, I think it's better to avoid in such kind of cases and in rest of the cases, because today in the CCC conference in Hyderabad, one of the delegate was telling their experience that there was a case of Marfan syndrome, and then they put the iris claw lens, and then the patient was very disturbed and telling that the objects are moving from here to there and there to here. So that was the experience which one of our delegate was giving it today. And I think we have to select the cases in which we want to put the iris claw and not blindly put iris claw in all the cases. I think that is the learning curve which we have to take from the patients itself. I'm not telling, although it's a debatable topic, I'm not going into that, but what the patient's experience telling also has to be taken into account. So thank you very much.
But that is where the 4-point fixation comes into, it has a role.
Sir, but tremulousness of iris even will be there, even if it's a 4-point enclavation also. If the iris tremulousness will be there, then usually we should experience that, is what I feel.
Yes. Okay. Slightly less.
Okay. Thank you, sir. Thank you very much. And now we have, thank you, Dr. Vaibhav. Wonderful presentation. Thank you. We have next Dr. Savio Pereira from Netradama Eye Hospital. Is a very young Turk and dynamic surgeon. I've seen him presenting so well in most of the conferences. And I think their hospital has done, they have published a lot on the 2-flange technique, the double flange technique also. So I want Dr. Savia to throw more light on this, the modification of Sergio Canabrava, where they try to do a 4-flange technique. Over to Dr. Savio.
Thank you so much, Dr. Srinivas, for the very warm welcome. Thank you, AIS, ARC, for the opportunity. And what I'll be presenting today is nothing but the modification of Canabrava's technique. And when we look at Canabrava technique, it was actually the technique which came out by the inspiration by Dr. Lewis, which started way back in 1990. When the SF-IOL technique, which he was inspired by, and the Yamane technique. So we have the first flange there, the second flange. This is originally described by Canabrava. 991, 993 was the original, which was described by Dr. Lewis, and he published the same. And then Canabrava came out with, based on Yamane technique. Now, what he realized that most of this required a lot of intraocular manipulation. And if you see, being anterior segment surgeons, we try to limit the amount of manipulation intraocularly. So what we saw with the Canabrava technique, I'll be describing the Canabrava, the classic technique first, and then the modification. So what was his technique? That you make, what are the materials? It's very simple. You don't need anything expensive. Just 5-O-Prolene or 6-O-Prolene can be used. Use hypodermic needles. 26 gauge is advised. We use 27. Your regular PMMA lens is what we use. And this cautery is nothing but, it's a bead burner. You get it available on Amazon. So you treadle 2 needles exactly 180 degrees opposite. You treadle them inside. Once you treadle it to one of the leading haptics, you burn, make a bead, treadle to the second haptic, again bead it, and then you gently pull both and it centers well. This is the video which is readily available and it is described by Sergio Canabrava, and the third and the fourth flange is finally done. So these are the 4 flanges what it's described by him. But what was our modifications? We use a pre-threaded 27 gauge needle. We use 6-O-proline. All manipulations are done extraocular. And this is very, very important, because if you have a bad cornea and you are planning a secondary procedure like a DSEC or any other procedure, it can be done, and there's very, very less chance of the IOL going down. So just to give you an idea, this is one of the cases which had come. You can see this is an entire CTR bag complex. This is a case which is referred to as bad pseudo exfoliation. And over time, you realize that these are the cases which may be not really great to save the bag. So yes, being a PMA lens, you need to make a scleral tunnel. You can go ahead and make a regular scleral tunnel like how you do for any of your SICS cases. Here you can see this was floating very well in the anterior vitreous, and that's the explantation of the entire CTR IOL complex. I use a trocar over here, as sir rightly pointed out, that there will be some amount of hypotony whenever you're doing a vitrectomy and you want the eye to remain tense. So you mark 1.5 to 2 mm on either side. You use pre-threaded 27 gauge needles. You just bring out one of the, by using any of the regular forceps. So you can see the needle is threaded. You go directly in perpendicular and then parallel. And here you can see, you can just gently push it in. Once the needle is there, you take another forceps, catch the proline and bring it out. So now basically you have both the threads out. And this is the important part, that you're threading the haptics and you're using a bead burner. This is all done externally. So there's no chance of your lens going down. At the same time, even if the cornea has poor visualization, you can go ahead and do this. So once you make a bead, you must make sure that it is larger than the diameter of the opening in the haptic. You can just do a gentle tuck to see that it's going to hold well. You can then do the same for the trailing haptic. There, you've checked it. You can do the same. And then once you place both, main thing you have to see that one thing is the threads don't get tangled. And that's very important, where I like to place the leading haptic in and burn the bead for this trailing haptic only once I place the leading haptic in. There you can see gently you can place it inside and at the same time give a little traction, and there, since it being a large 6.5 mm optic, you can now center it well. And this is the part where you can just keep a 2 mm length of thread and just create a bead. So here there is no scleral flap which is involved. There is no glue involved. And these burrs just get buried into the conjunctiva and then you go into the sclera. Make sure that they are very well covered. So these are a very simple technique. You can see there's virtually no chance of an optic capture because there's a large optic. And what really makes a little bit very easy, that it's very easy for any anterior segment surgeon to do this. You should be aware that hypotony, raised IOP, sometimes you can have a little intraocular bleeding, CME. These are the really important complications that can occur. And it's very, very important to see that you do not have the suture, the bead exposed, and that should be very well buried. And there are some of the late complications which do occur. But why do I prefer this technique? One thing is this very minimal intraocular manipulation, no handshake technique which is involved, no need for any scleral flaps. It's not at all time consuming. And what happens with the Yamane technique, we used to do a lot of Yamane technique earlier, but we do see there was some amount of tilt and sometimes the patient used to come with optic captures. And that was something which we wanted to avoid. And regarding RF IOLs, if there is iris atrophy or large sectoral iridectomy is done, or patients with colobomas, there you can have some amount of problem. So this is my preferred technique of the modified 4-flange canabrava technique. So I've kept within my time of 6 minutes also. Yes, sir. I'll be glad to take some questions.
Thank you. Thank you so much, Savio. That was really a fantastic presentation. Request Dr. Saurabh and Dr. Gurprasad sir to please throw their light on these. Dr. Saurabh, just a quick question is, even though we flange it, unless we make a 2 planar, right? So tucking back that flange into the scleral track, what we make, I think is very, very important. What Dr. Nagesh is also asking, that how do we prevent that exposure of those knobs, and how we can get a good bulb. I'm still yet to
Yeah.
find the answer for that. So any good technique you can just
Yes. So what I found that with this technique, there are a couple of issues. One thing is the IOL tilt chance is still there with this technique, and you have to be careful that the both sides, the direction of the flange should be same. Like means the inner side, if you are going over the haptic on one side, the other side also you should have the same. Otherwise, there is a torque motion once you secure the haptics. Second thing about the flange, what nowadays I do is that I make a small kind of a scleral tunnel. It's just maybe a 1 millimeter scleral tunnel just to tuck that flange inside. Because what happens that on table sometimes you feel that it has gone intrasclerally, but next day you find that it's still subconjunctival. If you don't have that, as you said, the two planar entry. So nowadays what I do, I make a small tunnel. It's just maybe using a needle itself and then use this flange. So this secures it completely inside the sclera. I think that is important because in the long term, the chance of extrusion and chance of endophthalmitis will be there if there is a this flange which is jutting just under the conjunctiva, which will thin out over the period of time.
Guru Prasad, sir.
So what I want to say is that yeah, the bead position is very important. It should be on the under surface of the eyelid, and not one on top and one below. So that's why the tilt up occurs. So both have to be on the under surface, because if it is on the surface, then it will rub this iris and cause iritis and all those problems. So that is one way of obviating the tilt problem. The other question that you asked was about the exposure. I always make a Hoffman's pouch. A Hoffman's pouch gives me the confidence to sleep at night, because an exposed bead, an exposed flange is always a time bomb when it will lead to a vitreous wick syndrome or an endophthalmitis in future. Maybe not immediately, but after a year or two, when you have delayed endophthalmitis, one of the commonest reasons is an exposed flange. And I dread the sight of the blue flange on the slit lamp if the patient comes on a follow-up. So I always, put a flap from the sclera from the adjoining area and cover it so that the blue color, even the color is not seen, not let alone the flange itself. So I believe in covering it completely with a under a Hoffman's pouch, which I'm able to do reproducibly and consistently.
Thank you, sir. Before we move on to the next, Savio, since you have published it, have you documented the ASOCT findings in all these cases? How much tilt do you see? What are the disadvantages of this technique? Although you have told more about the advantages, I do agree. I'm also doing a lot of this, and Dr. Guruprasad sir also, I've seen him doing a lot of this technique. But one or two disadvantages also, I think that completes the topic.
Yes. So the main disadvantage is there is nothing read about the flange size. What I would say is that, yes, use a 27 gauge needle and see that it is well covered. Now, sometimes you have patients with very brittle conjunctiva. They have undergone multiple surgeries, the retina surgeries, scarred scleras. Be a little careful, because then burying the flange becomes difficult. So you have to pre-select and see the area where you're going to be treadling those needles. That is very, very important, because if patient had a band buckle or a previous surgery, that area may be very scarred and it's difficult to bury it over there. So there you need to be really cautious. Regarding tilt, yes, we have done ASOCTs for our patients and we see that the tilt is minimal. The basic thing is you need to titrate it by pulling on both and keeping both the threads at the same time and then fixing it. So you treadle one, and then once you bury the bead, you do the second burn, and then you titrate it to see that the tilt is minimum. Optic captures usually don't occur because of the very large optic size of this. So the tilt is, yes, there is some amount of tilt, but it's not that much, provided the orientation is right.
Great. Thank you. Thank you, Dr. Savio. Thank you once again for that wonderful presentation. Now we move to another great surgeon, Dr. Ashray Naika. who has a lot of publications, and I requested him to speak on this particular topic, AC IOLs. I know most of us do not practice it, but I have seen from the Eye Foundation that they have beautiful presentations on the AC IOLs, which still works, and I'm really surprised by the results they have at their institute. So to complete the various techniques of the secondary IOLs, I request Dr. Ashwin Naika to please throw light on the AC IOLs.
Sir, are my slides visible, sir?
Yes.
Yes. So, firstly, thank you, Srinivas sir, Prashant sir, for giving me this opportunity. And I'm just, we don't really practice a lot of ACIOLs, but this is something which I wanted to put it in the right perspective. So, ACIOLs are really the things of the past, and we need to in my presentation, I'll have 4 sections. One is the literature review on the problems associated with ACIOL, and one unique case scenario where we used ACIOL, and also the medical legal cases associated with it. So if you look at the literature in 1987, out of the 1 lakh IOLs which they used, out of which 15% were ACIOLs. Cut to 2023, we have ACIOLs only used in about less than 0.5%. So this clearly shows that ACIOLs are things of the past. So, but however, a long-term study which included around 42, it's a meta-analysis which included around 42 articles, compare this technique of ACIOL iris fixation, sutured scleral fixation, and intrascleral haptic fixation. So, based on only visual outcome, there was no consensus on which secondary IOL technique was superior. But overall, the complication rates like anterior, CME, glaucoma, and retinal detachment were least in intrascleral fixation group, as described by the Shariat, Gaber-Shariat. So, why do we do surgery? The goal of any surgery is to restore anatomy. In this case, when we are talking in respect to ACIOL, the anatomy which we are very concerned is this circle, which is the angle. So what actually happens is in ACIOL, the placement anatomy has two major concerns. There is close proximity of haptics to the delicate structures like trabecular meshwork and corneal endothelium, and other one is the sizing of the IOL. So if this picture might not be very impressive, but look at the next picture, which actually shows the true untouchables of the angle, that is the iris, the corneal endothelium, and the trabecular meshwork. These are the ones which gave us a lot of complications. And as Kiranjit sir told, if we are able to do the best technique, if one person is doing, the other person should definitely do. And Shari's technique has been hands down given a very low complication rate. And that is the thing which we should all be doing, even though other things also work well. So why ACIOL got into disrepute? Because it touched those untouchables and caused all this chronic inflammation, and there was corneal decompensation. In fact, there was 16% endothelial loss in the first 3 years. And a recent article from Tang et al. Showed that 100% of the patients who had angle supported ACIOLs had corneal decompensation, and they also plotted a Kaplan-Meier survival curve, which showed that median corneal endothelium survival rate was only about 12 years. So when you look at long-term studies for 2 years, it makes no sense, because the truly long-term is about 10 to 20 years or 25 years, where ACIOL has really failed, and that's why it is very less used in this era. And also because it constantly erupts the iris, causes CME, and causes pigment dispersion and causing glaucoma. So all these cases that even Srinivas sir was telling, that when there is movement of images, the windshield wiper syndrome, or the ciliary tenderness, decentration, which causes glare and diplopia, rotation, iris erosion, hyphema, pupillary distortion and non dilatation, micro movement and corneal touch, anterior vaulting and corneal touch, haptic insertion in root, and the very infamous pseudophakic bullous keratopathy. All these reasons have made SUL very unpopular. And that is why, as my friend Nagesh clearly showed, that Chariot's technique, which also Guru Prasad sir also told, this 1.5 mm to 2 mm is where we have to steer away from this area to maximize the visual outcome as well as minimize the collateral damage, which any of the techniques which have been described by my predecessors. So, in fact, we can achieve refractive-like outcomes if what Nagesh explained in his presentation, if we take all those kind of precautions and tips, we can achieve excellent centration of the IOL and also have refractive surgery-like outcomes and even implant multifocal SFIOL. So this is a case, though I don't do SFIOLs, this case was done by a Shreyas, where patient had pseudophakic villus keratopathy in which there was dislocated PCIOL. So in this, we explanted the PCIOL and we implanted a Kelman ACIOL, which actually provided the scaffold for the air bubble, which we used to tamponade the desec lenticule. And once it was implanted, we put the lenticule and formed the air bubble and sutured the case. And this is one case where like we can't say ACL is absolutely irrelevant. In some unique cases, we can still use it. However, the other important aspect is the medico-legal aspects. This is a RK Tripathi case where the patient had subluxated crystalline lens after a blunt trauma. Patient did, the doctor did the anterior vitrectomy, but was unable to remove the nucleus. So he placed an ACL. However, later, one of the reputed hospitals in Chennai, they diagnosed that ACL was not explanted, was not implanted, or not after removing the ACL, or not removing the nucleus. So they explanted the ACL and they did a partial vitrectomy and a lensectomy. So in this case, the court said there was medical negligence for placing ACL without removing the nucleus. Here, ACL was not a problem, but the problem was placing the IOL without removing the nucleus. So here, another case which involved one of the past AIOS precedents. So where a patient had PCR and ACL was implanted, patient had a suboptimal visual outcome and later underwent ACL and ACL explantation and SFL was done. Though in this case was there was no negligence attributed, the case started in 2007 and ended in 2017. So this suboptimal visual gain actually provoke the patient to, yeah. So my take-home message is ACLs are definitely the things of the past. Chariot's technique and its modifications are safe and effective. Like Guru Prasad sir said, it's okay to lose the bag, but not your sleep. So be safe and do the best technique available. Thank you.
Thank you, Dr. Ashraya. I know it was a difficult topic and not many surgeons keep practicing about the ACIL nowadays. So it was challenging. Thank you for taking it up. Quick comments from Kiranjit sir and Dr. Pradeep Mohanta sir, please.
So I have tackled the worst of cases of ACIOL implantation, and they usually come with pseudophakic bullous keratopathy, and then CME is there in 99% of the cases. So what I do initially is I give the patients those non-steroidal anti-inflammatory plus inmycin capsules, then steroids, and let the CME settle down. Then I replace the lens with a 4-clip Scleral lens, and they ultimately do fine. Even the glaucoma subsides a little bit. So I think normally what surgeons do when they see vitreous presentation, they simply push the lens in the anterior chamber without clearing the vitreous. And the other point is sizing. AC IOL comes, I think I have never implanted any AC IOL, but it comes in two sizes. So if the sizing is proper, then this ICI will not cause much of problems. So if it is loose, it is going to dance in the interior chamber. If it is tight, bigger than the eye, then it is going to cause posterior or anterior vaulting, which may cause problems. So, but otherwise, it is out of the race now. This ACI will.
Dr. Pradeep, sir?
Yes, I have done a lot of ACIOLs with nice anterior vitrectomy, and if the size of the intraocular lens is proper and if it is placed in the right way, it gives beautiful result. None of my patients had endothelial cell loss. They had clear cornea for more than 5 years follow-up. Everything was fine. My experience is good with this technique.
Thank you, sir. Thank you very much. I think, thank you, Dr. Ashraya. Thank you once again. We'll
Thank
move
you,
on to the one last talk, and then we have two interesting debates coming in. So now we have a scleral tuck IOL with, again, another technique than what Dr. Parth described. This is another technique with the CMT flex. I think Dr. Nivian has invented this. And this is going to be presented by none other than Dr. Abhinav Dhami. Dr. Abhinav, go ahead with your presentation, dear.
Thank you, thank you, Dr. Srinivas, Dr. Prashant, for the opportunity. So I don't have any financial interest in this, and I think Vivian will be happy that I'm presenting it. And so the slide visible. So CMT definitely is a new way. It was actually the first time I saw Dr. Rana's IOL. It's pretty much similar, slightly different on the haptic part. So introduction, the CMT Flex was designed by Dr. Nivian as a new approach for scleral fixation. It is made up of hydrophilic material which contains about 26% water, and the refractive index is about 1.460. The optical diameter is the same, it's about 6 millimeters, but the length is about 13.75 millimeters as compared to Dr. Rana's IOL. And the best part is it has an angulation of 10 degrees, and the A constant has been fixed for 118. And so when we think of managing a phakia, I mean, it's pretty simple. My choices vary between whether the capsule is present or absent, or whether the iris is present or absent. I also am a big supporter of the iris claw. So if we have a capsule, anterior capsule is okay, posterior capsule is deficient, we just go ahead with 3-piece fixation. And if not, then we have the following options. My first two options are always the favorite ones. I either go with a CMT flex or a scleral fixation. My glued and Yamane are probably on the last approach. And if I have the additional support of the iris, then I might just go ahead with the retrofixated iris claw IOL. And if not, then I might think of it's an total anredia, then I'll go ahead with the analytic IOL. And if it's minimal iris is present, then again, CMT flex is the only way because it's easier, it's faster, it actually takes much lesser than as compared to the other IOLs. So this was the first video that's been sent by Nivian. This is the video where he first showed the case in which he's gonna has a case of phakia post PCR and nucleus drop, and we go ahead with making 2 flanges on either side, and scleral flaps are made 180 degrees apart, and then you have again as Dr. Gupta said, 1.5 to 2 millimeters is the right approach. I have played between 1 and 1.5. So the best advantage of this IOL, it's pretty much foldable, and you inject the first haptic. The care that you have to take is you have to hold at the T junction, not at the haptic edge. I'll show one of the cases where I made a mistake on that. And you can leave the other flange out, and you take the first, and you take the first haptic out, keep it there. It's not going to go inside because it's made through 23 gauge sclerotomy. It's not going to go out. No matter what even if you pull it out, it doesn't come out so easy. And while the other haptic is because it's made through a corneal tunnel, so the other haptic is secure inside the outer wound. So once you fix the one haptic, the other haptic just goes out very easily. You push the flap back and you retract it a little bit. He's using the Pranav forceps that he has designed too, and because these serrations are kind of blunt. And again, so the holding has to be done at the T point. It has not to be held by the tip of the haptic because that's going to break it. And I have had about 2 or 3 cases where I've actually had to bear the brunt of breaking the haptic. So this is it's easy, simple. We put the glue in. And the best part is the post-op astigmatism is actually pretty less. It's my variable has been between 1 to about 3. 3 only has been if the cornea was cut. And post-op day 1 outcomes are just fabulous. Not had and no need of any PI, nothing of that sort. So just to show my case now, and I have had I've run about 45 IOLs till now, last 2 years. And it's been absolutely
Management
wonderful.
of dislocated IOL with the Swiss Fold CMT SF IOL. We present a case of an operated cataract surgery done elsewhere, with a dropped foldable intraocular lens, managed with the Swiss Fold CMT Flex Scleral Fixated IOL, as designed by Dr. Naveen from MNI Hospital. We start with 270-degree conjunctival peritomy. Bipolar cautery is applied to bleeding vessel. The scleral flap marker is used to have 180-degree marking at 3 and 9 o'clock hours. 180-degree partial thickness scleral flaps are made. Partial thickness superior corneoscleral entry is made using a crescent knife. 3-port 23-gauge vitrectomy is done. We induce a posterior vitreous detachment using active suction with vitrectomy cutter to free the IOL from any vitreous adhesions. The peripheral vitreous trim 360 degrees. We use the intraocular forceps to bring the IOL in the anterior chamber. Scleral tunnel entry is made using a 2.8 mm keratome and the posteriorly dislocated IOL is delivered out. 23-gauge NVR-assisted scleral entry is made 1 mm behind the limbus to fix the haptic of CMT Flex IOL under the scleral flap. Iris claw holding forceps is used to insert the CMT Flex IOL in the anterior chamber. Intraocular IOL holding forceps assisted the T-shaped haptic are brought out on either side at 3 and 9 o'clock hour position, under the scleral flap where it is well secured. The IOL is well centered with minimal tilt or torsion. The scleral flap in the conjunctiva is opposed with the help of fibrin glue. In the end, the Swiss Fold is a promising IOL for the future in managing aphakic correction, using scleral fixated technique.
So, this was a very confidence boosting surgery, and I went ahead with a second. This is my second case just after the first surgery, and this is where I made the mistake which I had to learn from Naveen. So the haptics can break if you're not careful, and you have to be slightly gentle with them. And the first haptic always comes out very easy, nothing, no problem at all. So you pull it out nice and easy because I'm holding it from the T point. The second time this was actually a traumatic dislocation. I was under the impression, okay, I pulled it out and I held it from the tip of the haptic. And the moment I pulled it out, and you'll see that the first part of the haptic comes out and then the remaining part of the haptic just breaks apart. So the only point of learning in this haptic is that you have to really hold it from the T point, otherwise it can break. So my experience till now, I've had no refractive surprises till now. The astigmatism varies between 1.5 to 3. Haptic breakage in the 3 cases itself. IOL dislodgement has been minimal. No secondary glaucoma, nothing of that sort. And the other advantages is that it's easy foldable implantation. There's minimal learning curve. Any retinal surgeon or any internship surgeon can do it. There's no sutures involved. It is actually assistant free. So you don't have to depend on an assistant to hold or you put a silicone sleeve on the haptic, nothing of that sort. Disadvantage, some amount of haptic breakage can happen, maybe in the early cases. Eventually you learn on it. Some pigment dispersion on the IOL I noticed in a couple of cases. Extreme powers are plus minus. I'm not sure if they're still they are giving it out. And that's from my side. Thank you.
Wonderful. Thank you. Thank you for those beautiful videos, Dr. Abhinav. Dr. Saurabh, Dr. Guruprasad, sir.
Yeah, I think we discussed this in the previous one. It's a good IOL, and I think Dr. Abhinav also told about the problem of breaking of the haptic, but I think it can be taken care of. I think one thing is it's better to use the serrated forceps which Dr. Abhinav showed rather than using the end grasping, or sometimes we use ILM peeling forceps, whatever we have available. It should not be used. We should have that serrated forceps, which will reduce the chance. So, and also the holding the T junction as he showed. And initially, what I would advise is that when you're making those scleral incisions, 23 gauge, rather than making it parallel to the limbus, you can make it perpendicular to the limbus so that T is perpendicular to the scleral incision. So you can make it little larger than the 23 gauge, not too large, so that when you are pulling out this T, there is less resistance, because that is the point. If there is a lot of resistance, you may cut the haptic.
I think I totally agree with Dr. Saurabh. Even I wanted to make that point. It should be like a plus. So make a vertical this thing, and then the T will sit in the horizontal position. So I think that will give a more grip, because in case if we have to extend, then it becomes a problem when you take when it is parallel to the limbus. So I think this is much better is what I feel.
Yeah, and even sometimes when you pull the second haptic out, and if you pull it too jerkily, if you have the parallel to the limbus incision, it may get pulled inside also if you have made it little larger. So for beginners, I think this perpendicular incision is much safer that way.
Agree.
This lens is from Apasami. Is it from
Yes, sir. I think
Apasami?
Apasami is marketing that. Yes.
Okay.
Guru sir, any comments?
Yeah, I just want to tell that I have no personal experience, but I've seen the videos and I imagine that it's a question of doing a couple of cases before you know the amount of the handling that you have to do, not too rough. That is what I mean, and that is what is going to probably save your day by not causing breakage of the haptic, breakage of the teeth. I think it's all about a couple of cases, and after that, I think it's easy to perfect. It's not much of a learning curve.
And one more important tip is when you inject the IOL, when you hold the leading haptic with the forceps, inject the IOL completely, just leave the trailing haptic, but don't pull out simultaneously as you do in maybe the Agrawal technique or Yamane technique where you put the haptic into the needle and you simultaneously take it out. Don't do that. So first push the IOL completely and then only pull out the leading haptic, because that may also cause breakage of the leading haptic. So that is one more, I think, tip we should remember.
Thank you, sir. And Dr. Giraj asked that question. I think I just want our expert panel to tell that since we are making 23 or 20 gauge stab incisions in these things, so using a glue probably will seal this. This might prevent the post-op hypotony, is what I feel. Rather than suturing it, there can be a little bit of hypotony, especially when we are making a 20 gauge entry, then definitely gluing it will give a definite good closure. That's what I feel. Any other reviews can be discussed.
Yes, I think glue and put air in the anterior chamber before you close. That will reduce the chances of post-op hypotony and optic capture, which may occur sometimes.
Actually, if you're using a Scleral tunnel, then you have to do a partial FG in the vitreous also, because if the air sometimes comes out from the Scleral tunnel. But if you're using a corneal incision, then it's okay. You can just put air. Then the hypotony is just minimal.
I just had a comment to make. Can I make it once again?
Yeah, quick, Vaibhav. Yeah.
The Carla Valley lens also has a similar concept. And Dr. Stratos from Greece has, taken out a different modification of the haptic. So what he does is, after making the stab incision, instead of making the flaps, you explant the T. And what he does is he's made a tunnel on both the sides of the incision. So you basically place the T, the ears of the T underneath the tunnel after explanting it. So you don't require a flap in that case. So you have a vertical incision, you take it out and you place it under the Scleral tunnels.
Well, taken that well. Thank you. Thank you for that point, Dr. Vaibhav. Now we come to last two interesting debates. Now it's very controversial because iris claws, many anterior segment surgeons use that, but posterior segment surgeon says no and no. There are very few posterior segment surgeons who still love iris claw, but still it's a debatable topic, and so it's fought by two young surgeons. Dr. Tanvi Haldipurkar will be saying that, yes, I have seen Dr. Suhas Haldipurkar sir doing it for so many years. And yes, definitely it works well. And then I am also following his footsteps. And now Dr. Tanvi is going to say about the iris claw are simpler and better. Over to Dr. Tanvi.
Hi, can you see my slides?
Yes. Go ahead.
All right. So good evening, everyone. Today we are talking about secondary IOL choices. It's interesting as both work very well, but my preferred choice is the iris claw. Let's see why. For me, it's a simple, easy method of implantation. When I started my cataract practice and I had to deal with surgical aphakia, sometimes done by me and sometimes referred, I found the learning curve for the iris clip was much less. I found it less daunting and it had a shorter learning curve for sure. So when I was already bogged down by the PCR that I had created, I felt that this technique was a saving grace and it gave a good postoperative outcome. But why should you take my word for it? Let's look at some literature. So this is a study done by Nguyen et al. It did a comparative analysis of 104 post-cataract aphakic eyes, and they looked at iris claw versus sutureless SFIOL. And they saw that 56% of the surgeons chose to do iris clip as a primary surgical procedure, and in the entire set of eyes, 50% of them had the iris claw IOL implanted. So I think this highlights the simplicity of the procedure, even when the surgeon is mentally bogged down by that, which is what mostly happens with a beginner. One can still plow through and put an IOL in the eye using the simple method. They found that 3 IOLs in the SF-IOL needed reintervention. A point to be highlighted here is that a good amount of vitrectomy is needed. I think the debate definitely is between an anterior segment surgeon and a posterior trained doctor, because a primary vitrectomy, an anterior segment surgeon may be hesitant to do. And he may land up doing an incomplete vitrectomy, which can then cause some entangling of the vitreous while doing the scleral fixation. And that leads to some sort of traction later on. We also know the SF-IOL puts a hole in the sclera, so that's a potential connection from the out to in, and sometimes can cause even an hypotony due to the leak, and therefore risk of infections are much higher in an SF-IOL as compared to an iris clip. This was another study done by Rao and Shashidharan et al., which looked at 30 eyes which were implanted 4 weeks after surgical aphakia with an iris clip IOL, and 80% of them had good vision and very minimal endothelial cell loss. Another study which said that the long-term stability, they looked at around 3.5 years post-operatively, and there was no statistical significant difference in the endothelial count at the end of 3 years. So if you are still convinced, there are many, many more surgical studies that have looked at a long-term stability, safety of the iris clip lenses. But at the end, you have to decide which complications will you want in your patient. So to conclude, I would say the iris claw should be anyone's choice because the mean surgical time it takes is significantly less. Studies have shown there is no statistical significant endothelial cell loss. We know that the visual acuity is better on day 1 than an SF-IOL. And I think first impressions are lasting. So a patient who can see well on day 1 will definitely be happier than someone who may take weeks or months to recover. Iris clip is less invasive. The postoperative complications are less, and it is much easier to remove in case of any issues. We know the surgical technique is simple. It requires minimal vitrectomy, can be done by a non-vitreretinal surgeon. And I think a little or minimal dissection gives a faster postoperative recovery. Very importantly, it can be even done in small pupil cases, can sometimes be the case. And I think it's a practical option when the last case in your list lands in a loss of back support and you have to then think of implanting some sort of lens in that eye. Just to show a case in the end, this was an ectopia lentis patient with almost more than half a quadrant of loss of zonules, where we chose to implant the iris claw as a primary procedure. It was a very soft cataract. It just popped right out there. What we did is after removing the nucleus, which only required just a cortical or an irrigation aspiration, just a minimal anterior vitrectomy was required, because here we are not trying to disturb the anterior vitreous space too much, just enough that we can put a iris clip lens. We cleared the central area, and through a 5 millimeter incision, we put the iris clip lens. As already being shown before, the surgical techniques are similar. You need to check whether the openings of the iris clip are present, and then this is the iris clip holding forceps that you can use. I'm using a spatula here to just tuck the haptics in. You can either do it from either side port. I'm doing it through the same side port. First I did on one side and then just retracted back and did on the second tuck as well. Here we need to make sure the anterior chamber is always filled and the endothelium is safeguarded. In the end, you just take a suture and it really takes less than half a minute. Sorry. So I would say that there is no one solution for everything. Like all the panelists and our esteemed seniors have discussed, iris clip definitely is a good option, but there may be some cases where you may not need to or you cannot use it, but it definitely is something worth learning in your initial beginning years. Thank you so much for your patient listening.
Beautiful. Thank you, Dr. Tanvi. You really presented it very well and points well taken. Let's hear from Dr. Giriraj and then we can have a 30 seconds of rebuttal. Dr. Giriraj is also a very dynamic surgeon. So he'll be contradicting your technique, telling that SF-IOLs are definitely much safer and better. Over to Dr. Giriraj.
Are my slides visible, sir?
Yes, yes, yes. You are visible and audible as well. Please go ahead.
Thank you. Thank you, ARC and Srinivas sir and Bhavan Kule sir for this opportunity. Yes, Dr. Tanvi spoke eloquently about the iris clause. She conveniently missed out on some points. I'm going to highlight them. Don't worry. So I will start with saying do what is right and not what is easy. I would like to quote Bhagavad Gita also, that the right way which is there, it may not be the easiest one. So the message is, don't go for the easy surgery. Think what is the best for the patient. So I would think, why would a surgeon want to do an iris claw lens? When they run into a complication, they lost capsular support, iris claws are easily available, patient gets vision on the day one. These are the points put forward by Dr. Tanvi. But what are the points where why they don't want to refer this patient? Is it ego that why should I refer it to someone else? Is it because they think that the other surgeon will take their cases? Or is there any other reason? I fail to understand, because as a vitreoretinal surgeon, we never tell that this is because of a cataract complication or this is because of a poor surgery. We just say that the bag was weak and we would do whatever the best for that particular condition. So when we were learning, we were taught that the iris, you have to treat it with respect. Iris bahar aa raha hai, आसानी से अंदर रखो, pupil circular रखो, iris को damage मत करो. Sort of like iris को लगना चाहिए, कभी कभी तो लगता है मैं ही भगवान हूँ. But when you treat Bhagwan like this, they are doing iris claws in front of the iris, behind the iris, they are suturing the iris, they are basically butchering the iris. Oh my God. And if this happens, what will happen? The God gets angry. He will do Tandava Nrutya inside the eye. What is Tandava Nrutya? Iridocyclitis. Yes, we can see. And those who have managed iridocyclitis, they know how difficult it is to treat those patients, how difficult it is to counsel these patients for the recurrent episodes of iridocyclitis. This is another patient who had to undergo demake because of the endothelial cell loss. And you can see how the iris is irregular in shape, patchy iris atrophy is there all around. And you are placing the iris claw IOL on a movable structure. What is this? This is the IOL dancing, pseudophacodonesis, which is definitely not good for the patient. The shaky vision syndrome has been discussed. Let's consider that this lady with most beautiful eyes in the world comes to you. And what you have done? You have put an iris claw lens. What is happening? The ovalization of the pupil. This is again, do you want to do that to the most beautiful eyes? No, obviously not. What is this? You can see in the second eye. Anybody can say that the second image shows a horror movie, isn't it? See, in the same way, there is horror movie inside eye going on. The IOL is moved away from its natural position and it is hanged somewhere superiorly. So she presented with this article. I would like to say the same article. It has also it also says that eyes with iris claw experience significantly more post-operative iritis, intraocular pressure spikes, ovalization of the pupil, and visual rehabilitation following iris claw IOL might take longer than SF IOLs. Okay, and there are so many other articles which I can go ahead. This is our own study with 100 patients in each group. It also says that vitreous in AC, hypotony, pupil ovalization were seen more in the iris claw group than the SFIL group. So bhaiya risk hai, iris claw bole to risk hai. There are so many other articles, Scleral direct comparison between the SFIL and iris claw. It also says that scleral fixation is the only option in case of severe iris damage. In traumatic cases where there is no iris, what are you going to do? The SFIL is the only choice there. Removing the iris claw, when one side gets disenclaved, what will you do? You can't refix the same IOL because there is a patchy iris atrophy. And removing or disenclaving the other side of the iris claw, it carries its own risks. It can cause iris tear, it can cause iris hole, or some surgeons recommend cutting the IOL, and that itself is again risky procedure, causing additional trauma to the iris. So in the end, I would just like to say that if you want to give the patient temporary vision, go ahead with aphakic glasses or aphakic contact lenses. There is nothing wrong in counseling the patient about future long-term good vision. So sutured IOLs, glued IOLs, CMT flex IOLs, there are so many safer and efficient technique and better techniques are available. So in the end, I would like to say for myself, if I want to sleep peacefully, I would choose SFIL over iris claw. Thank you.
Thank you, Giriraj. You have bought Ramayana, Bhagavad Gita, everything into this thing. Kiranjit sir, I think he was also looking with the eyebrows because he is an iris claw lover. I would like to hear from you. Dr. Saurabh is also here. Yes.
It's in a lighter vein, but yes, I would say whatever technique works best in your
No,
hand.
but one thing, Dr. Giriraj, you told about entire Ramayana and Mahabharata, but you did not tell which SFIOL is better. Which
Yeah,
technique is better, you did not.
if
Okay, we'll give 30 seconds rebuttal to Tanvi. Yes, Dr. Tanvi.
I can always take that later, but since you got the Bhagavad Gita in, if you don't remember, Bhishma Pita lay on a bed of arrows. It's just your direction was pointed wrongly. Those arrows kept coming. And this clip is like that. Iris is very, very good. I don't think that if you look at the surgical training, if you look at somebody or want to learn an SFIOL versus an iris clip, finally it is the hand which does the job. It would be much easier for somebody to do an iris clip. And I work in a place where there are vitreoretinal surgeons right next door. I'm married to one. So it's not the ego that prevents us from getting them into the OR, but just the simplicity of the procedure.
Yeah, agree. Totally agree.
But what I feel is the thing is you should do the right thing even if it takes more time. That's the thing that has gone into my head.
Absolutely. Each case has its own, we need to look at it in total. It is not what is available. It is not what you need to do. But as I think even today, this scenario is that anterior segment surgeons should know how to do an SFIOL. So very interesting to see a lot of newer options coming up, which are easy. So definitely something to have in our armamentarium.
Thank you. Thank you very much. Dr. Saurabh, any quick comments before we go to the next debate?
Yeah, I think as Dr. Tanvi said, I think we many times compare two different types of surgeries, but what is more important is also the surgical skill involved. So I think in a good surgeon's hand and experienced surgeon's hand, either of the technique which he is used to or she is used to will work equally well. And both the techniques have their own set of complications. So if the iris claw maybe has more chance of say pigment dispersion, then SFIL may have more chances of say retinal issues also. So I think both have, I would say, work well in 95% of cases, but all cases where you are not putting PCL in the bag will have 3 to 5% patients who will have some issues with either of the technique used. So it based on the experience of the surgeon, he should choose what is best for his patients.
Yes, Ashray, a quick comment and then we'll move on to the next. Kiranjit sir wants to.
Yeah. I can say something about the pigment dispersion. Firstly, the pigment comes from the back of the iris, and once the lens is fixed to the back of the iris, it becomes a part of the iris, so it moves along with the iris. But in case you have some kind of tilt, IOL tilt with the PC IOL, SFIOL, then that viper, what is that called, shield viper syndrome, that is going to shed away pigment from the back of the iris, and that will cause the pigmentary glaucoma. And this is what I wanted to say about the iris claw is never going to cause pigmentary glaucoma.
Sir, last comment. The basic premise of this argument is about anterior segment surgeon trying to manage a posterior segment complication. So there is no harm in if they do the posterior segment procedures in the right way. But if we are trying to fit in your solutions to a different problem, that is the problem. I think when we have a rock solid data, we should follow the data and prefer not using what works best in your hand in the interest of the patient's visual outcomes.
So main is when you do a lot of vitrectomy and hypotony occurs, then the dreadmost complication of choroidal hemorrhage can occur with SFIOLs. And when we are implanting a iris claw lens, we are working in a closed chamber with the interior chamber always filled with a viscoelastic. So chances of choroidal hemorrhage are minimal. So that is also a difference. This time at the IIRSI Delhi, there was an issue with choroidal hemorrhage in a case of this glued lens, which was ultimately managed very well.
Okay, thank you, sir. I think that's why it's called as a debate. It's never ending, and everybody has their own points. And thank you very much, Dr. Tanvi. You presented excellently, and Dr. Giriraj, you fought back very nicely. Thank you, both of you. So we'll move to the last debate of today by two erudite speakers and excellent surgeons. Dr. Apurva says, "Why remove the IOL? One haptic dangling. Fix that. Save money, save time, and it's better for the patient also." And Divakan says, why doing all those heroic procedures? You just remove the SFIOL and put a simple one. The solution is over. So let's hear from Dr. Apurva. Over to Dr. Apurva, please.
Hello, everyone. Thank you, ARC, Dr. Prashant and Dr. Srinivas for having me in this debate. So my topic is refixating dangling SFIOLs. So, right. So what could be the causes? It could be spontaneous, maybe suture degradation, or it could be trauma. So let's look at this case of a 19-year-old boy. He had undergone an SFIOL surgery in 2009 for subluxated crystalline lens due to Marfan's. Now he came back after about 7 years with posteriorly dislocated SFIOL, and there was one haptic that was dislocated, causing the optic also to go back into the vitreous. And so this is, as you can see, the suture remnant of the previous surgery, which is in the eyelet of the SFIOL. So what are our options? Explant and remove and put another SFIOL, like Divakant would say, and maybe some sulcus fixation methods by using a suture for single fixation, or exteriorize the haptics. And let's look at what we did. So this is a very elegant technique where we did a vitrectomy first. We freed the IOL from its vitreous attachments. And then what we did was we made a clear corneal, a translimbal passage of the 90 proline suture, docked it through the bed of the scleral flap. And then we went inside and bimanually dissected out the suture remnant of the previous surgery. We use a chandelier here. And then what we do is that we make another entry using a 26 gauge needle. And what we do now is use a forceps, intravitreal forceps, and take it through our sclerotomy ports and thread the suture through the eyelet which was dangling, of the haptic which was dangling. And then we remove this suture, that suture which we threaded just now, with a 25 gauge forceps out of the sclerotomy that we did in the scleral bed. So I'll just show you how this turns out. So what we have is two ends of the suture outside. What we do is just tie a simple knot, and lo and behold, the IOL is recentered. So this is our dangling haptic. And this is what we do. We translimbally pass the 90 proline, bring it out through the scleral bed using a 26 gauge needle. Then we go through a pars plana port, thread this other end of the suture through the eyelet of the haptic. Then we bring it out through a 25 gauge forceps, because this was a 23 gauge vitrectomy, mind you. This is 2016 video. We brought it out through the scleral bed again. And what we have is these two ends of the suture, which we very easily tied. So look at the centration of this SFIOL. And this is a closed globe internal refixation of a dislocated SFIOL. Now let's look at this surgery. Very similar. I think due to paucity of time, I will not show. I will just show the very relevant steps. We are doing the vitrectomy, relieving the vitreous adhesions to the IOL. Using a chandelier technique, we are again, we put a chandelier, pass the suture through the limbus and through the scleral bed. Then we go in, thread it through the eyelet and bring out this other end of the suture through the scleral bed. And we just tie it outside and close the scleral flap over it. It's beautiful. So the next one is this surgery, which we did using the canabrava technique this time. There was a one-sided dislocation of the SFIOL secondary to trauma. And then again, we are seeing the dangling SFIOL. We removed the vitreous around the IOL. Vitrectomy was completed. So now what we do is we put in a chandelier, and this is the pre-threaded 60-prolene what Dr. Savio was mentioning before. We pre-thread it and we take a 1.5 mm distance and put this suture inside. Then we exteriorize it. I'm sorry, we use the forceps to go in, and again we thread it through the eyelet of the SF-IOL. Once the suture end is threaded through the SF-IOL, we actually bring out the suture end and we make the bead using the cautery, as you can see. Now we've made a very secure bead on the eyelet and we check that it's not slipping back. Now it's very simple. We bring out the other end of the suture through this conjunctival tract that we have made with a 30 gauge, and then we make a bead, and that's it. The IOL is recentered. Very beautiful. So I've shown you 3 cases. There is no limbal wound needed to explant this SF-IOL, which is dislocated. No astigmatism, obviously. It doesn't need to have any exteriorization of the haptic. You don't even touch the haptic. There is very minimal manipulation, and it is a totally internal refixation, which is through a closed lobe.
Just looking like a wow.
Right?
Just looking like a wow.
This is the meme which is very famous, so beautiful, so elegant, just looking like a wow. So what do you think?
That was a nice one, Dr. Apurva. So let's hear from Dr. Diva. Dr. Divakant?
Sir, I'll just share my screen.
Yeah. Please, Dr. Diva.
Yeah. Just a second, sir, I guess.
You gave up your fight, Diva, or?
No, sir, not at all. My video is, there's some issue there. Okay.
How many cases of SF-IOL they dislocate one side after a period of 10 years or so?
That's a very pertinent question, sir. It is quite rare, honestly. So we usually see that it is post-trauma that it dislocates.
Okay.
So the suture degradation is quite uncommon, we should say, but we do see post-trauma that this does happen. And we've probably seen about 5 or 6 cases, considering the long history of our institute, because our mentors have done SF-IOLs since the 2000s or even before, I think. So I think a long-term study has shown, I think, around 2 to 3% of suture degradation over time. I think there was a paper in AJO in 2003. So
yeah.
Yes, we'll come back to you, Dr. Nagesh, very soon. We'll finish this from the Dr. Deep.
Sure. So my slides are visible?
Yes. Go ahead. Visible and audible.
So I'll be talking about the external fixation of the IOL and why it is the best option in such cases. A small video before that. This is a case with a surgical aphakia that presented to us with a somewhat open scleral tunnel that is visible right here. So we did 3-gauge, 3 ports we made, and this is the PMMA IOL that is dangling here. We have done some vitrectomy, removed the vitreous around the IOL and lifted it up with the help of a forceps. So that is the IOL right there, and with the help of the McPherson's, a quick in and quick out procedure. Then the choice of IOL in this case was a CMT Flex. I use that often these days. So 2 small, I think the technique has already been discussed in this meeting, but 2 small pockets, scleral pockets, 180-degree apart. I use a slightly different technique of making these pockets, but whatever works for the surgeon. Now so this is the IOL right here, And from the already opened scleral tunnel, we'll insert it. And with the help of a 23 gauge forceps, we will simply, as the technique has been defined, with the help at the T junction, we'll hold the IOL and bring it out. And later this can be either glued or sutured, right? So coming to Apova's video, I feel compared to that, this is a simpler technique, simple and beautiful. And I feel it is more reproducible. All of us are not as gifted as Apurva in terms of being surgeons. So this has a minimal learning curve. What I feel that there's a lot of manipulation that was happening in Apurva's case, and most of us probably will not be able to manage it well without any iatrogenic trauma. So as Dr. Giriraj has said, Tandav happening inside the vitreous cavity. So not everybody will be able to contain that. Another aspect is that a lot of patients, recently I had a broken haptic and I was trying to do the surgery, and I was discussing with my colleagues that let's reimplant the same IOL. And from the table, the patient got really agitated that don't put the same IOL, it's a faulty IOL, bring in a new one. So when you're trying to counsel the patient, that also becomes a valid point. And coming to Apurva's case, also when there are suture issues, there's always a chance that the same issue can happen to the other side as well. So we can have, after a few years, the other may also, detach and lead to the same issue. So thank you so much. Over to Apurva.
Hi. So yes, it requires a lot of dexterity. And honestly, these are my mentors' videos, Dr. Guru Prasad and Dr. Srinivas. So I have not done these surgeries myself. So point taken and touche. So second, I agree with the brand new mentality. I think patients do have that thing that, probably this IOL is defective. That's why it has dislocated. So just put a different one. So I agree with you on that.
Okay, thank you very much. I think it was, Dr. Nagesh, coming to your point, you said, why don't you try to suture the haptic, externalizing it and do that? See, as they were telling that minimum manipulation is always better in these kind of techniques. I think Dr. Guru Prasad sir will explain it next. So if you try to bring it out, then definitely you are going to damage the other haptic also. So if you try to, pardon your question, when you try to bring it out and then suture it. So it's always better, if you want to really do an internal refixation, then it's always better to suture it in the vitreous cavity than bringing it out, doing that and then putting it back. Otherwise, the next day itself, we can see that the other haptic is broken. Yes,
I mean to say, I just wanted to clarification. Like when the both sutures are, broken, if it is completely floating IOL, what I do, I'll just bring the haptics to the small side port outside. And from the 3 o'clock position, I bring the suture, pass to the eyelid, and then keep the haptics back inside, and then bring the other haptics to the haptic through the side port and do it off. That's a quite simple, elegant technique that you can do, so that you can avoid, chandeliers and then doing all the circles inside.
Both the haptics are in the vitreous cavity.
In fact, most of the times we do get a single suture breakage. When I go inside, I'll try to manipulate the IOL and see how good is the other end. Invariably, the patient will come back with other end suture breakage, because once one side suture is broken, we should assume other end of the suture is compromised. We don't know when it will break. So I'll try to manipulate and see if it comes out, it breaks out. I will be very happy if it breaks out on the table, so that I can refixate both the ends. And that will save one more surgery from happening. That's how it is.
Yes, Guru sir and Dr. Saurabh.
So what I want to reiterate here is that the suture biodegradability is one thing which causes the dislocation. The other thing is there is a possibility of the haptic being held not just by the suture but by the granuloma granuloma that forms in the ciliary surface. So it is not just a suture. Even if the suture biodegrades, a suture granuloma would have formed maybe a fibrous ring around the IOL, which is why it doesn't come. Which Dr. Nagesh was saying that he will, if it is dangling, he will pull the IOL and check for the other haptic, whether it is fixed or not. In fact, that was the idea I got on the table when I was operating on this on the first patient that I did out of the 7 or 8 cases that I've done so far. The first time when I did it, it was not a pre-planned internal fixation. I wanted to explant the IOL, but the second haptic was not coming. In spite of pulling almost very, forcibly, it was stuck and the entire globe was getting indented in that area from outside. So I got an idea, why to cut it, why to cause bleeding, why not just try to do an internal fixation. That is how the process started. My thinking process started on the table, and I got those ideas spontaneously on the table while I was operating on this case. So I think Dr. Nagesh has a point, but it is not just the biodegradability. It is also the fibrous ring that forms around the loop or the haptic, which holds the lens and not the suture alone.
Yes, sir, because I had done similar, quite some number of cases
Dr.
like
Nagesh, I
this.
think Dr. Prashant sir is
Yeah.
catching a flight, so
Oh, yes, sir,
he
yes, sir,
will
thank
make
you.
a point and then we'll come back.
Yeah.
Yes, Prashant sir.
No, I wanted to add one point. I would prefer, see, once the one suture is degraded, I would even have a doubt about the.
I think this network is bad. He is catching a flight. So yes, Dr. Nagesh, you were telling a point, and Kiranjit sir.
Somebody was telling me that Dr. Jagat Ram has published a paper on SFIOL where he has fixed the lens to the sclera with the help of a steel sutures. So those sutures are not going to disintegrate at all at any point of time in the life of the patient. So just a passing remark.
Yes, Prashant sir.
Yeah, I was making a point, Srinivas. The thing is, what I prefer to do in such cases when we have a single piece lens, not a foldable lens, where we have a I would cut off the dangling haptic, not the haptic, the suture which is attached one part, then have a proper look at the lens. If the haptics are intact and well having the integrity of it, then I would do a scleral fixation of the lenses by externalizing, even if it is a rigid single piece IOL, as in the cases which have been shown. That tend to have more better stability because of the longer arc length. And so that's more safer and more easier. And that is what is internal repositioning, which we can do very. Myself and Dr. Sangeet Mittal does a lot of these things. Even a rigid IOLs we do with a single piece lens.
Thank you, sir. Dr. Saurabh.
Question for Dr. Nagesh.
Yeah, Dr. Dr. Pradeep sir, go ahead.
If it's a PMMA lens with, can you bring out the haptic outside and put the thread? Dr. Nagesh.
You mean to say it is a suturing SFOL with PMMA lens?
One haptic of the PMMA lens has suture.
No, one haptics, it may be difficult because that will create a lot of traction on the other end. But what I'll do, I'll just bring it to the iris plane. From there, I can suture it at the anti-segment level. So I no need to go inside and then with the chandelier system. So you just try to place the other end, the suture end which got broken onto the iris, then I can pass through. If the both ends are broken, I can bring it to the side port and then I can resuture it separately.
Can you bring out through the opening outside the sclera, PMMA haptic?
No, I mean to say the clear side port incision at the limbus. That's where I bring it out and then suture it.
Okay,
I mean, it's difficult to explain it, but so this is how I do it.
No, we'll have again series 2, Dr. Nagesh. Don't worry. We'll have Jawans 2. Before Shah Rukh Khan releases the next Jawan 2, we will release the IOL Jawan 2. So don't worry. We'll come out with more other innovative techniques. Last comment from Dr. Saurabh and.
Yeah, I think these are relatively quite rare cases, and the decision has to be taken, as Guru Prasad sir said, on table, what you feel is the best for the patient. But yeah, the plan initially will be to explant the IOL and put a new one. But on table, if you feel that the other haptic is well fixated to the sclera, I will go with how Guru Prasad sir or Srinivas has done in his talk. So it depends on case to case. I think.
Thank you. Dr. Saurabh is being very diplomatic. Thank you. Thank you very much. To be very frank with you, me and Prashant sir, when we were discussing and making this webinar, we thought that it's going to end in 1 hour. Because we had kept only 6 minutes talk, but it's 2 hours and 10 minutes, and still many people have many questions and many other ideas. I think it's wonderful to have all these expert panels here. Thank you very much, Guru Prasad sir, Dr. Saurabh, Dr. Kiranjit sir, and Dr. Pradeep Mohanta. And the icing on the cake was definitely the speakers. I think the Young Turks did really, really well. Definitely we'll have more and more debates next time. And we'll come out with different, very specific topics we'll give rather than having a broad kind. So this was just part 1. Then we'll come out with season 2 also very soon. Thank you all the speakers for their fantastic show. And thanks to Dr. Prashant Bavankule sir for always believing in his ARSC members and giving us an opportunity to do more and more. Thank you, Prashant sir. I think we'll all pose for a photograph if you can switch off your this thing. Sunil, I request you to please take a photograph.
Thanks to Prashant.
Thank you, Dr. Prashant and Dr. Srinivas, for this opportunity. It was wonderful, good learning.
Yes.
It's our privilege. I'm boarding, so I'm keeping mum.
Thank you, sir.
Okay, so it's a photograph taken, Sunil?
Yes, sir. It's there, sir.
Great. So once again, thank you, everyone. Good night.
Thanks,
And
Prashant,
Shabak hai.
Thank you, sir.